So case number 2, got a 73-year-old guy, 90 minutes of dense right-sided hemiparesis. Call that code stroke. The initial head CT is negative. Nobody sees anything. Now what do you do? So what if no blood, right? So we just crossed out the hemorrhagic side. A non-con head CT is pretty darn good to pick up blood. However, we don't really know if this is an ischemic stroke or not. So if no blood, TPA of severe, maybe. So this presentation's already at like 170 slides. So believe it or not, I cut like 100 slides off of it. There's a lot of myths of thrombolytics. If you really care, you can listen to me talk about it for an hour on YouTube. I'll send you the link. Here's a horrible physiology slide. Don't have time for it. So STEMI versus stroke. Very similar conditions in a lot of ways. You got a blood vessel not giving blood to something that's important. That tissue dies. Person doesn't do so hot with dead tissue. So we tried TPA for STEMI, and it works pretty darn great. There are 9 major trials, very consistently had benefit of both mortality and patient-centered outcomes other than mortality, such as functional outcomes, and more benefit the earlier you gave it. There's a very clear line of, look, if someone came in and you actually push lytics within an hour, they do better than the jokers that come in at 4 hours. They do better than the folks that come in at 6 hours. It's very clear. There's not really much questioning on that. The earlier you give TPA to someone having a heart attack, if that's the therapy that you're using, the better they do, okay? What about stroke? Well, if you see in the prior slide, we had nearly 60,000 patients versus 8,000 patients for stroke. So a lot fewer people. Most of those studies are negative. We're going to blitz through them. And there's a much higher risk of intracranial hemorrhage, which is the thing that kills people as the side effects of TPA. There's also not a consistent benefit of giving this drug early. Now, a lot of people are just going to say, oh yeah, the earlier you give it, the better they do. And they'll have absolutely no trial data to support that. It just doesn't exist. I'm sorry. So let's check the scoreboard. You got more people on the STEMI side. Always a benefit on all those STEMI studies. Very clear trend versus the stroke side where it's all over the place. You got a time-dependent improvement with the STEMI, makes sense, versus the stroke where it really doesn't. And then 1 in 250 with head bleeds versus 1 in 20 with head bleeds. And that number is very consistent, that 5 to 7% of the people that you give TPA for ischemic stroke are going to have an intracranial hemorrhage. And about half of those folks die. So you could also say 1 in 40 people that you push the plunger of that drug will die because of that drug. It might still be worth it in some people because if you're saving more than 1 out of 40 of those folks because of the drug, it's okay. But every time you order TPA for an ischemic stroke, 1 out of 40 of those people die. So let's review the trials. There's 12 of them. We're going to scream through these. Please note the color at the top. So blue, no benefit. So it's a neutral study. We don't really know. Green is a positive study which says, oh yeah, we should actually be using TPA. And red was either stopped early or it had some harm or futility. So it was actually actively negative. Let's look at what we get. So the first one, MAST trial. Neutral, not really clear. Looks like you kill a lot of people, but the disability rate went down. I'm actually okay with that. I am shockingly comfortable with killing a bunch of people if we get better functional outcome. Because what I'm not trying to do is create a whole bunch of people with terrible quality of life. I would much rather roll the dice and say, oh, if we had a 50-50 shot of you either dying right now or having a great outcome, I'm actually comfortable with that. So this actually doesn't bother me. ECAS 1, please note that a lot of the studies that were positive have numbers after them. They all had negative trials before that one was positive. You'll notice a trend. ECAS 1, negative, no difference. With TPA, less than 6 hours. NINS 1, negative, robustly. This is the only one of these studies that ever looked at the Lazarus effect, which is we're going to check it at 24 hours. Every neurologist has a study, the story of, oh, I was pushing the syringe, then 5 minutes later the person was doing phenomenally and they had this dense hemiparesis and now they're able to do algebra. It's great. They didn't even know how to do algebra before. I taught it to them in that 5 minutes. It's great. And that is absolutely not founded in the trial literature. Their human experience is great. And I feel wonderful for that TIA that they just treated. However, that drug doesn't work that way. It really doesn't. And the reason we know that is whenever they looked at it in the trial studies, we have never seen it. At 24 hours, they were no better. The only data that looks positive was when we look a few months down the road, which is not what we're talking about. That's not the Lazarus effect. So NINS 1, the only major trial that actually looked at the Lazarus effect, robustly negative. NINS2, oh, now we got our FDA approval. We'll talk more about this later, but this is the one that said you could give it in less than 3 hours, okay? MAST in Europe, stopped early due to harm, 47% mortality. Good gracious. Cut it off early. The ASK trial, another one, stopped early due to mortality. Pattern emerging. ECAS2, also negative. ATLANTIS-B, which actually came before ATLANTIS-A for reasons unclear to me. Stopped early due to no benefit. ATLANTIS-A, still not good. DIAS-2, nope, not working. ECAS-3, oh, the first two ECASs were negative. Let's just keep going. Oh, yeah. Between 3 and 4.5 hours, might have a favorable outcome. We'll pick that one apart in a minute. IST3, I actually put this as neutral. They reported it as positive, and they lied to you. They really did. They basically made up their own primary outcome that was never part of the study and said, yeah, well, we didn't meet our primary outcome, but we met this one. They moved the goalpost. It's a neutral study. So let's look at the number of trials per result. So this is the absolute number of trials, and you say, oh, well, surely those on the right just had way more people in them, right? No, they didn't. They were two of the smaller studies that were actually the ones that got the approval. Far and away, the largest one was an unblinded one, which is IST3, which had so many problems, I don't have enough time to tell you about them. Oh, and this is just me being a jerk right here. This is what would happen if those that were stopped early because they were killing people were allowed to recruit the number of people, so they just were allowed to keep killing people. This is what would have happened, okay? So it looks even better for TPA, doesn't it? So there's not a Lazarus effect. It's the Kirk Lazarus effect. Those of you that have seen the movie will get this. Never go full Lazarus. So, so the problem is you just aren't identifying the right folks here. If you push the plunger and they get better, they probably weren't having an ischemic stroke. But this is the thing that makes it so that you can't have this discussion. They don't want to debate literature with me. They really, really don't. Okay, the people that believe in TPA believe in it because of those anecdotal stories. They were there in the room and they pushed the plunger and the person's doing algebra a few minutes later. Unfortunately, I sound like a jerk because I'm telling you that's not how the drug works. It just doesn't. So you have a self-serving bias because we want to believe that the stuff that we do actually helps people. I'm guilty of this as much as anyone. Hindsight bias. I knew that when I pushed the lytics, this is what was going to make it better. And then belief bias. It's consistent with your belief. If you unclog the tube, the blood gets to the brain, surely they do better.